So thank you very much, and very sorry not to be joining everybody in person for this very interesting meeting. What I'm going to run through briefly this morning is a little bit similar to what you've just heard, but with some extended data about the ongoing efforts of recovery, and to talk a little bit about what NHS England and the cancer programme have been trying to do to make sure that we recover the situation that we found ourselves in with the pandemic. And so I'm going to talk a little bit about the drop in numbers, which is fairly familiar territory, some of the things we're doing to bring people back into the system and some of our case finding pilots, and a little bit of talk about our operational performance and some of the challenges I think that we all recognise we have in front of us. So this is the number of patients for all types of cancer referred on the suspected cancer referral, so-called 2-week wait pathway. And you can see that we dropped briskly in early 2020 in response to the pandemic, as everybody recognises. But actually, the recovery across the piece was pretty rapid during later part of 2020, dipped again, but to a much lesser extent during the next wave of COVID in the winter of 2020-21, and really has been running at pretty high levels ever since then. And certainly urgent cancer referrals in November last year, which is the most recent month for which we have the operational data, they were running at about 125% of pre-pandemic levels. The important point to recognise is that we see approximately 3% compound growth of cancer incidence year on year at the moment as a result of the changing demographics in the population. And the rate of 2-week wait referrals has been running significantly ahead of that. And actually, during the last decade, 2-week wait referrals have been going up about 10% a year, such that we saw 2.8 million people on a 2-week wait referral last year in England alone, which is an extraordinary number, and as much as anything else reflects the huge amount of hard work by colleagues in primary care, seeing and referring people in. And I think 2-week wait referrals currently constitute about 25% of all GP referrals to secondary care. So this is the numbers specifically for urology. And what you can see is, again, coincides with what you've just heard from the audit, that the numbers were relatively slow to recover during the latter part of 2020, but that actually we've been above the previous level since late 2021. And again, this is operational data from the cancer waiting times data sets, which shows you that we've been running at pretty high levels for the past year, essentially. And of course, it'd be interesting to discuss the reasons for that. I think a lot of it during the early part of the pandemic was people not going to see their GP, not having those conversations about PSA testing in particular, which often results in the referrals. But very interesting and very encouraging news we'll talk about in a minute. That little blip in March 22 actually coincides with the risk awareness campaign that we ran with Prostate Cancer UK. Which is really heartening, because the NHS spends a lot of money on various sorts of awareness campaigns, advertising campaigns and so forth, and it's sometimes quite difficult to demonstrate real impact in the real world from these things. But this is actually very encouraging, and I think an important lesson for the future about how we should go about doing these things. Now, the other challenge is these two curves show you the 2-week wait referral numbers as a percentage of prior levels, and then in orange below that, the actual treatment numbers following a 2-week wait referral. So this is not all cancers, this is only the people who come through the 2-week wait referral pathway. And what we saw, of course, was a very rapid drop in 2-week wait referrals early on, and then during the next 9 months, a pretty steady recovery. And during that time, at least, treatment volumes kept pace with referral volumes, largely because the numbers actually had been quite low and there was much less pressure on the system. Since about getting on for 2 years ago now, we've been above pre-pandemic levels of referrals, as you can see on the blue line there. The difficulty we have is that our treatment activity has not kept pace with that. So we've got the orange line, which is going along. It's still above previous levels, and we're still treating record numbers of people for cancer overall. But unfortunately, it's not going up quite as fast as the referral rate, and it probably isn't going up as fast as the numbers of people being diagnosed with cancer. So we are in difficulties, and again, this is very familiar territory for everybody working out there that we're struggling to get the cases through and to get people both diagnosed and treated. And again, this is looking specifically at the numbers in urology. So this is not just prostate, but this is across urology. But of course, the dominant driver of these numbers is prostate cancer. And again, we can see the same phenomenon, the big drop in referrals early on, referrals coming back up, treatment keeping pace for a while, and then slightly losing touch. And clearly, we've got more to do in accelerating both diagnostic and treatment capacity increases. And I should say that a lot of the gap between this is probably sitting in diagnostics rather than in treatment. But obviously, flexing treatment capacity to increase theatre times and get people onto radiotherapy machines is still quite challenging. So again, big effort, lots going on, and we've been above historic treatment levels for getting on for a year now. As you can see, we've been about 100% with that orange line, and it is still rising, which is very encouraging, but clearly big challenges in the system, making sure that we have the capacity to do this. So to go back, and you'll hear a bit more about this in a minute from Chiara, but actually this was a joint venture between Prostate Cancer UK and NHS England, and I think one of our most successful campaigns, helped of course by some very useful tragic celebrity prostate cancer diagnoses and deaths indeed, which happened around the same time. And we do know that, of course, famous people talking about their prostate cancer has a huge effect on awareness and people's likelihood to seek help. But channeling it through the prostate cancer risk checker on the website, I think was extremely helpful. And Chiara will go into more detail on this, but essentially we had more than 1 million people went onto the risk checker. We saw 2,000 extra men starting prostate cancer treatment, and we think this is probably around the 4,000 men mark now. So a big recoup of the people that we would have expected to have started treatment who didn't during the pandemic, who've now started to come forward. We've also been working with the Cancer Alliances in a number of locations to try and see what else we can do to proactively bring people into the system. Obviously, there's this perennial problem of not wanting to do screening by PSA testing, but at the same time wanting to get to the most communities most at risk, particularly Afro-Caribbean men, of course, but also more deprived populations as well, where we know that the rates of diagnosis in early stage are much lower than in the well-off. So a number of cancer alliances have been working in the east of England to go through ICS, to go through primary care records, to look at high-risk target cohorts and invite them in to discuss PSA. In Greater Manchester, we've got practices sending texts to men at risk. And down in West London, we've got the Royal Marsden Partners Man Van going out and about, again, targeting at-risk communities, offering information, making sure that people understand their risk profile, and a number of other initiatives going on, again, to try and make sure that nobody can be unaware of the possibility of getting PSA testing, getting referred for investigation. As I say, we have significant capacity challenges, and one of the things I'd really like to explore in the discussion is what more we can do in this area and how we can address some of these challenges that are in front of us. We're putting very significant investment into diagnostic capacity, in particular in community diagnostic centres, to try and see if we can streamline investigation, and this is particularly, of course, about cross-sectional imaging, things like MRI, to increase the number of tests we deliver by about 2.9 million by the end of this financial year, and 17 million extra tests over the next 3 years. So a lot of money going into expanding diagnostic capacity, particularly CT and MRI. There's also, of course, the hospital building programme, and there's significant money going into additional theatre builds, in some cases new hospitals, but in many cases expansion of existing facilities on acute sites. And finally, something which I think we haven't made enough of yet, but which I think we need to discuss more and work out how we can do this better, is the introduction of our best practice time pathways to try and speed up the diagnostic pathway, particularly for prostate cancer. And prostate still constitutes one of our largest backlogs in terms of diagnostics and treatment when we look across the country, and certainly where we look at the trusts which are struggling most with their prostate cancer diagnosis and treatment capacity, we find that very few of them have managed to make progress on this best practice time pathway, which I think in the places where we have managed to implement it really has made a big difference to the way that people experience their care and the speed with which they arrive at a diagnosis. This is the version of the pathway where we go straight to test using multiparametric MRI. There's another pathway where if MRI isn't appropriate or for one reason or another, but I think it's important to highlight this because, as I say, in my conversations with trusts who are struggling with their backlog, I hear quite often that for one reason or another, it's very difficult to implement this. And I suspect a lot of this is to do with MRI capacity, whether in scanning capacity or very importantly, of course, in reporting capacity. But I think it would be helpful to have a discussion about what more we can do to encourage this process whereby we move from clinical triage straight to MRI prior to biopsy and try and shorten the time between imaging and biopsy to make sure that we're getting people the answers they need in a timely way. Because certainly when we look at the faster diagnosis standard and the proportion of people who start treatment within 62 days of an urgent referral for possible prostate cancer, we are not doing well at the moment. And I think there is huge scope for improvement, but I think it is going to require some significant work on pathway redesign and making sure that we've got the resources in place for that. And be very interesting to pick up with you how you think we might go about doing that and what the real roadblocks are for that. The most challenged providers out there, the so-called tier 1 providers, are getting particular support in this, and that's the group with which we've had the most meetings to try and help them to get on top of their 62-day waits, particularly looking at elements of patient choice, whether patients can be treated at other locations, whether we can redesign the pathways, as I've said, how much we can do in things like outpatient transformation, remote reporting for moving around for example, the MRI reading capacity, and working with cancer alliances to try and make sure that where there are real bottlenecks, we can put specific funding in to break those down and to overcome the difficulties. I know that Getting It Right First Time programme have also been looking at surgical productivity and prioritisation and thinking about different ways to make sure that we're absolutely making the best use of the resources that we have. And of course, the nuts and bolts as well of making sure that the waiting lists are effectively managed, that we haven't got duplication of patients, that patients are being discharged effectively when we know they haven't got cancer. All of those things are also very important. And again, very heterogeneous practice around the country about the way in which different organisations manage their waiting lists. A letter went out, I think, yesterday or the day before, asking trusts particularly and particularly those challenged trusts, to prioritise their community diagnostic centre capacity for patients with cancer, to do things to help with the colorectal pathway as well, to make sure that they're making the best possible use of local capacity, and to make sure that they've got effective management of the waiting list. So lots of work going on to try and help with the recovery of the situation, but there is no doubt that we are still under considerable pressure with the prostate cancer pathway in particular, constituting a very large part of our current backlog of people. So I will stop there. Thank you very much indeed for listening, and I'm very happy to pick up some of those points in the discussion.